Appreciate the members of Finance and Insurance being here today. This is basically a hearing with our Department of Insurance to go over and discuss an issue that we have a bill that is on the floor today on state-based exchanges, and we want to get more information, make it available for y'all to ask questions. If y'all have any questions or concerns about the state-based exchange. And so at this point, I will turn it over to Commissioner Cheney. You and all your folks there that are with you, y'all feel free to kind of interchange and explain. They have a handout, PowerPoint they're going to be going through that's on the screen and in front of you. So Commissioner Cheney, take it away.
Thank you, Mr. Chairman. We do have a PowerPoint, and we're going to kind of tag team this deal so you don't always hear the same guy. A lot of you. I will tell you this, when I served in the legislature, I never got this much attention from senators when I was there for the 8 years. So I'm glad y'all all paying attention this morning. Kind of unusual. So Ms. Mercer, I hope this clicker works. We're going to see. So this is an overview of the proposed state-based marketplace in Mississippi. I know it's current as of this morning. I'm going to let David Browning kick it off for a little bit. David's Deputy Commissioner. Everybody here knows David, and he's going to cover half of it, and I'll pick up on the backside. So David.
Thank you, Commissioner. I just want to kind of give an overview real quick, and we'll go through these fairly quickly because I'm sure there'll be questions, along the way. But, really, there are three types of, marketplace exchanges. There's a full state-based exchange. There's a state-based exchange, which is operated on a federal platform, and then is the federally facilitated marketplace, which is what Mississippi is currently in. And really, the difference between the state-based exchange is, state-based exchange, the full-fledged one is, the state operates every aspect of the marketplace. The state-based exchange on the federal platform, really the only thing the state does is, they handle, individual market and things like that, but enrollment and all that still handled, and you still use the federal platform, and you still use their website and marketplace to enroll individuals and stuff like that. So it's kind of a hybrid approach, with the state-based exchange federal marketplace. I will say that, if it's decided to convert to a state-based exchange, you have to participate on that state-based exchange federal platform, I believe, for the first year, and then you can convert to the full state-based exchange where the state handles all aspects. Next slide is just showing, what states have what. You have about 19 states that are on a full-fledged state-based exchange. You have 3 states that are on a state-based exchange but operate on the federal platform, and the rest of the states, and that light colored, is on the federal marketplace exchange. These are just, some numbers right here, just kind of give a snapshot, of where the current marketplace stands. Right now, we have about 286,000 enrollees here in Mississippi. Some of these other categories just show, kind of the ones that receive the subsidies and the cost sharing arrangements. You'll see that, really that last column there, 98%, marketplace enrollees receive tax credits and, cost sharing arrangements. So a majority of the people that are in the marketplace are receiving some type of subsidy and reduced premium. You want to the next page right here just kind of shows the breakdown by age and, male, female, the different types of plans, majority of the people in that silver plan. And then, at the very bottom right there, this kind of gives a snapshot of how that, premium tax credit works. So you got a gross premium of $616 monthly premium. And then once you kind of factor in these tax credits, you kind of see, what someone that's receiving, a subsidy is paying per month. It's a heavily subsidized premium, which, like I said earlier, is a majority, of the people that are enrolled are receiving some type of subsidy there.
So moving along, when you look at what legislation would be required to do a state-based exchange in the state, CIO, which is the Center for Insurance Information Oversight, which falls under CMS, is a big dog in Washington that requires all the states that have a state-based exchange to confer appropriate authority to whoever's going to run it, and that would be the insurance commissioner in just every state. So typically this is done by legislation. We didn't put on this slide, but you normally would have to get a signature from the governor to approve the operation of the exchange. You don't have to have his signature to enact legislation, but you would if you were going to operate an exchange. And the reason for that is the governor is the person or the entity that's looked at to operate Medicare, Medicaid operations within the various states. So it's always the right protocol, keep the governor involved. Everybody's got to be on the same sheet of music. The implementation timeline, many of you had asked about this. If you started in July of 2024, that's this year. This is basically what would happen if you tried to do a state-based exchange. Let me say, I don't think this is it's a realistic timeline, but we're not going to have an exchange established this year, even if you pass legislation. All you would do is have the tools in the box to be able to do an exchange down the road if it were required after an administration change in Washington in January of 2025, which is probably going to happen. So in the first year, Mississippi would operate a state-based exchange on the federal platform like Arkansas, Oregon, and Georgia is doing right now. The total estimated fees collected are between $56 and $59 million. However, when you look at a state-based exchange with a facilitated platform, the state will only retain 18% of those fees the first year. So the first year you do have some operating costs. You can recoup those fees over the next 4 years, but that's where the federal government's actually holding the hand of the state-based exchange to make sure you can operate it on the state level. There's generally a 3-month delay between the time user fees are actually paid and they're paid to the state because fees are generally collected on a quarterly basis. And that's true for things that I don't want to confuse you, but it's things like cost sharing reduction, which we're going to get into. That's where the federal government gives subsidies to the people on the exchange to reduce their out-of-pocket expenses and also to reduce their maximum benefit per year, like you got a $5,000 out-of-pocket maximum during a year. So that can be reduced down to almost zero. And it gets complicated, but the bottom line, that's why the feds want to try to move people off the marketplace and put them on Medicaid so they can give them free money. We're against that. I just tell you up front so you know where I stand on it. I think it's a bad policy to take people that are paying for insurance and try to give them something for free. Moving towards a fully state-based exchange, Mississippi would be working towards standing up the full state-based exchange. It'll take us about 2 years to do this if we actually start doing an exchange. To minimize the financial impact or the fiscal impact on the state would request no direct development and implementation costs during the first year. We have the dollars available in the Mississippi Comprehensive Health Insurance Risk Pool Association, better known as MCHRPA, that's available. We did discuss with you, the chairman of finance this morning a little bit about we may or may not need legislation. It depends on which lawyer group you talk to. But basically, I don't see a problem. We've got the dollars there. We decide that's where we want to get the money. In other words, you could start an exchange up without any general funds coming out to finance the exchange. So funding the state-based exchange, the money flow for a state-based exchange is fairly simple. The customer selects coverage on the state-based exchange just like they do now on the federal facilitated. Some of them will qualify for a tax credit. They still get the tax credit. So if you're between 100 and 150% today, if you go back to the sheet that David showed you about number 3 or 4 slides here, it will tell you how much it actually costs you for a policy. It's less than $30 a month. And some of these numbers are going to vary a little bit. You'll see some at $625, some at $696, but that's because of you're dealing with the government. But the real number is probably a little less than $600. So we just try to hang our hat on a happy medium when we're figuring money out. So the state exchange assesses carriers to pay for the state-based exchange. Mississippi retains those user fees. It's a smoke and mirrors game. The federal government pays the carrier. The carrier in turn turns around and gives $3.50 today back to the federal government out of the money the federal government gave them. Do y'all understand that? It's a little smoke and mirrors, but that's how it's funded. In this case, the people that own the exchange would end up paying $2.25. I think that's the number that we'll actually come up with off of every $100 they take in on premium, and that would go to operate the exchange. Instead of going to the federal government, it would come to the state to operate it. The state gets part of that fee. The federal government would still get their cut to pay for the platform that we're using. So when you look at the funding, and this is it's all boiled down to this right here, where the money comes from. If you base on a 2024 projection, if you base a user fee, it would be 2.25% net that would come to the state to operate out of the premium that the consumer would pay. And that's actually coming from the federal government. The average monthly premium, and I told you it ranges all over the board. This number, when we did these slides, or when we were doing the analysis back in October, November, and December, the average premium was $698. Based upon all the plans in Mississippi, the average premium's right a little bit under $600. So that's maybe it'd be $100 high here. The state healthcare.gov enrollment is estimated for Mississippi at 286,000 people. That's how many people are estimated to be on the exchange today. We think the number is a little high because when you look at who's actually paid for the premium, it's about 240,000. And it's kind of weird that people won't pay the $29, but the government makes you pay the $29 and then they turn around and give it right back to you. But that's how you get enrolled. But that's the way they operate. We would operate it probably where you get a credit like the other states are doing. So the estimated payment to the healthcare.gov under this scenario would be $54 million. The cost savings to Mississippi is we're paying the federal government more money to run and operate the exchange right now than it would cost to keep the funds in the state to run a state-based exchange. So if you look at for 2023, the Mississippi carriers paid the federal government 2.75% of the gross premiums collected on the exchange enrollments last year. And the enrollments last year were about somewhere under 150,000, very close to 130. So that's equivalent to more than $42 million in 2023. And when you look at the significant 20% increase in enrollment in 2023 for payor year 2024, it sounds complicated, but it's for how many people actually enrolled in 2024. The payments to the federal facilitated marketplace in 2024 will only increase. They're going to keep going up, and the enrollment's going up. So the consumer selects coverage on healthcare.gov. It would qualify. They may qualify for a tax credit that moves over to the insurance carrier, enrolls the consumer, and sends a bill for the user fees to the federal government on a quarterly basis. Federal government pays the carrier, but withholds 2.75% of each plan that's sold to pay for healthcare.gov. That would drop to 2.225 if the state runs it. So we actually pick up money. The federal government gets their little cut that they want to get. And that's kind of where we go from. And I'm getting pretty close to the end. I'm trying to do this, so I know y'all got a lot going on. If Mississippi had a state-based exchange, the state would have an assessment fee. The average savings would approximately be 50 to 66% of the user fees currently paid to the federal marketplace, and they could be reinvested into programs within the state. So the consumer could select the coverage and just keep going right on through. It's fairly easy to look at the coverage here. And the state exchange on the last box over here would assess the carriers to pay for the SBE operation. So it's an assessment process. You understand kind of how, any questions so far? I'm going to come back to questions momentarily. So these are the cost savings. And if you look at what it would be over a 5-year period, it's between $137 to $196 million. The estimated total cost for operating the state-based exchange is between $18 and $27 million. That's basically the same number I gave y'all a couple of weeks ago when I was in front of the committee. I told you we think it would be around 19 million. The estimated annual savings are 28 to 37 million. So that would come to the exchange. The state could decide what they wanted to do with it at that point. It's important to understand that if we do operate a state-based exchange, we'd have to have a call center. And being creative, you might want to put it in Canton, Vicksburg, Brandon, Terry, somewhere where you got close proximity to the capital, but you also have fiber networks. And now that we have rural, you might want to consider putting in Greenwood and Greenville. You could do that, or Cleveland, Mississippi. So a call center could go somewhere, but you got to have a base to handle the calls, and it's going to be about 300 people. We've got people that have already contacted us at the department about operating the call centers, and they said they could operate them wherever you wanted to be operated from. So that would be a legislative decision. You talk about job creation, this may be some of it right here. And you may actually use the facilities that are in Madison. You've got 2 call centers in Madison now, if y'all know where I'm talking about, going up I-55. So the user fee projections, this is just a recap of where some of the money's come from. You got a recap of the total projection fees, how much we get, how much the federal government gets. The benefits to Mississippi, you return the savings back to the Mississippi consumers. You can create a state funded reinsurance to lower consumer premiums, so you can buy reinsurance for some of those savings and actually lower the premiums more than what people are paying now. And you can invest in state-specific plans. We told the chairman this morning, I thought it was important to put in what would be needed if you decide you want to go to conference and try to work on a bill. These are some things that we would recommend that you put in to have the best flexibility. This is based upon the experience of the states that have actually done a state-based exchange. There are 19 that have done a full-fledged state-based exchange, and 3 more that are using the facilitated marketplace because in the first year or second year of the operation, that's Oregon, Arkansas, and Georgia. So, Mr. Chairman, that's basically it on the PowerPoint. I'll be happy to take any questions or whatever you'd like to do, sir.
Thank you, Commissioner. Let me think of- So basically, what you're saying is that the 3 forms of the marketplace right now is just the federal facilitated marketplace, which we currently have right now. There would be a state-based exchange on the federal platform, which would be mandatory the first 2 years.
Correct.
Then you could stay on that platform, or you could change over to strictly a state-based exchange where the state does everything.
You would go to a state-based exchange. You'd still use their software and their platform, but you'd be operating it totally and not the federal government.
Okay. In, I guess, your conversations with other states, I see Georgia, Arkansas, and Oregon look like they have the state-based marketplace with federal platform. Is that because they are in that 2-year period, or is it because they chose to stay in that?
Oregon's a little unusual. They just decided to stay where they were. Georgia and Arkansas are in a 2-year period. Arkansas actually changed their plan a year ago, so they had to go back and be what we call state-based on the federal platform. And the reason for that is that they chose a plan that we originally had 10 years ago, where they take the Medicaid money and they actually buy a bona fide policy for all of the folks that are on the exchange. And then they tried to mess with it 2 years ago, and the feds made them go back and reapply all the work. It's kind of complicated, but
What's the situation with Georgia? I guess are they the most recent ones to do this?
Georgia's the most recent, and John King's the commissioner in Georgia, a good friend of ours. We talk to him quite frequently. Actually, he'll be here in May along with 13 other commissioners. We'll discuss state-based exchanges. Kentucky has an exchange, Virginia has an exchange, and we're looking at, there are 5 other states in the South that are looking to form an exchange. They're kind of like we are. They're trying to get the ducks in a row to do an exchange if they have to do one in January.
What other states are looking to do one?
Louisiana is actually looking at an exchange. Texas is considering something, but Texas is political. It has very little to do with what's going on with the consumers. It's more political about who gets coverage and illegals. And Alabama's looking at one right now. And Mark Fowler was with us, the commissioner from Alabama, at Mississippi I-Day last week. And I think their legislation, I do believe it passed. I don't really know what's happened yesterday, because they're kind of like, legislators and legislatures or wait till the last minute sometime. That's what Alabama was doing. But they were trying to pass it this week because I think their next week is a sine die week for them. But they're looking for it. The governor wants it. Governor Kay Ivey, who's very much thinks a lot like our people over here in Mississippi. And then we've got Georgia. Florida can't figure out what to do. Mike Dabrowski, I got to get his name right, says they've looked at it, and Governor DeSantis just hadn't made a decision on which way they want to go. At least that's the word we got Monday. South Carolina's considering it. North Carolina is trying to do it by executive order, so it's all over the board. Everybody's trying to figure out what to do. Our job as commissioner is to bring it to the legislature and let y'all make that decision. If you want to go enable us to operate one, that's your decision. We're going to do what the legislature tells us to do. Make that very clear.
What is the next 5 to 10 years in this space look like, as far as what trends are you hearing, as far as what health insurance, I mean, I know you don't have a crystal ball, but what do you think the trajectory of this is going to be, and where, I guess I'm looking for pitfalls. What changes may be out there? What are our opportunities, and what are the things we need to be concerned about or looking in the future towards?
There are 4 pitfalls that we see. Basically, the major pitfall is the federal government pulling funding. I don't see that happening because you affect so many millions of people. It's not tied up in the budget right now, but I see that as a potential pitfall. That's probably not going to happen. There's consideration and talk in Washington about trying to put people that are on Medicaid on the exchange. So if you connect the dots, that's why SOCIO is trying to push expansion of Medicaid to 138%. I don't think that will happen. I just don't think Congress has an appetite to let them do that. But that's always a possibility 5 or 10 years down the road. You don't know what's going to come out of Washington. That's a potential pitfall. The other one is that we go into a very, very deep recession within this country, and people can't pay even $30 a month for health insurance. That could end up being a pitfall, or the federal government doesn't fund us on the user fees. So that gives you an idea of kind of where we're headed. Of course, as you have administration changes in Washington, the rules may change for the ball game. So we just want to be prepared for whatever comes down the pipe, Mr. Chairman. And if we have something in place, we're not saying if y'all gave us the authority to operate exchange, would certainly come back to the legislature and the governor before we ever try to implement anything. That's something that we would do, but if we're prepared, we can move very quick and be very nimble.
Okay. Senator Kirby for a question.
There you go. Thank you, Mr. Chairman. Commissioner, I was just looking at this. It says state exchange assesses carriers to pay for the operation. So in other words, you have to be a member of the exchange to be assessed. Is that what I'm reading, or is it just assessing all carriers?
It's only the assessment is only on the people that are on the exchange. It's not on all the carriers. It's just right now we have 5 companies on the exchange, and they're assessed based upon each policy.
So if you're not a member of the exchange, you will not be assessed.
You do not pay an assessment if you're not a member of the exchange. So we have our large domestic is not on the exchange. They would not be assessed anything.
I was just wondering if there was enough money, but I guess you got that figured out. So, all right. Well, thank you. So it's not going to assess anything but the health carriers that are on the exchange. Is that what you're saying?
That's correct.
Okay.
Senator Kirby, if you do some quick math, the numbers are approaching $2 billion in premium that are paid on the exchange, and just run 3% of that. That's 60 million. That all those numbers are jive, and they change a little bit on the quarter points, but that's the numbers work together based upon the premium.
Thank you, Commissioner. Thank you, Mr. Chairman.
You said there's 5 companies that are currently on the exchange?
There are 5 companies currently on the exchange, and all of them seem to be healthy and happy. So you'll understand how that works, and sometime in July, August, we'll start getting preliminary requests to approve the rates that they will charge next year based upon the medical loss ratios that they have experienced in 2023. So a medical loss ratio is simply a federal rule that says that if your premium base is above a certain level, 85% of all the premium that you take in has to be spent on medical procedures or medical costs, and that includes drugs and et cetera. You've got 15% for administration, overhead, salaries, whatever you pay your people to work. If you're a small base company, it's the 80% threshold. So we have to adjust the premiums. The companies bring all the data to us. We have actuaries that look at the data to know if they're within that 85% range. If they are not, they have to lower their premium base. And that's happened. Bob Williams is all y'all know. He's the director of life and health over the department. It gets complicated, but because of time, I'll just say that we have to approve all the rates, and we do that on actuarial opinions. Our deadline is somewhere, I think they let us go up to the 1st of October this year, Bob. So we have to October 1 to approve the rates. And when people say that we don't approve rates, we do, but it's based on actuarial opinion within the narrow scope of the law. It's all in statute. We follow some really strict guidelines. We're very cognizant of the fact that every time we make a decision at that department over there, we affect 3 million people's lives. You don't shoot from the hip on insurance. You've got to know what you're doing.
Is
I
there?
wish I could say that about property and casualty and insurance on the coast, but I can't quite get there.
What, do you think there's any potential to add more players, bring in more?
We are, right now, we have probably close to 70 companies that sell some form of health insurance in the state. We would probably add as many as 4 or 5 more. They would be small players, but they would have niche markets for people that are high income, that need a special policy, individual policy.
Who all is eligible to purchase on this exchange?
Anybody can purchase on the exchange as long as they make 100% or more of the federal poverty level. That's $15,000 for a person of 1. It's almost $100,000 for a family of 4. Anybody can buy off the exchange as long as they're above the 100% poverty level.
Senator McMahon for a question.
Yes, Mr. Chairman, thank you. Commissioner, why are you wanting to create this? What's driving this conversation?
Oh, let me be certain I understand. What's driving the conversation to have a state-based exchange?
Yes, sir.
Well, I think the driving force was that the House passed some legislation to establish the state-based exchange, and I think they did it based upon whatever they thought was necessary for the state to cover people down the road. And it got over to the Senate, and Chairman Harkins, in his wisdom, decided maybe I better look at it. He got blindsided like I did, and we're looking at it. Senator, I didn't request it, but I will tell you that it's probably good wisdom if you have something, a quiver in the arrow or a tool in your toolbox, however you want to say it, to be prepared if something comes down the road in January.
It seems as though but it seems to me that the entire program is going to be operated on user fees. That's the whole premise. What if we have a president in 4 years that waives all the fees?
Well, it's important to understand when you talk about, we call it user fees, but basically the companies that sell are going to pay for the operation of the exchange. And the way they get their money under the tax credit portion of the plans, the federal government gives them the money. And they in turn give us however much of that federal government money they get to operate the exchange. It's just pretty simple. It's not coming out of your pocket direct, but it's coming out of your pocket somewhere. And let me make it clear, if you say this is increasing my federal taxes, it's not, because what's happened, we're already paying that money and somebody's going to get it. I don't like to say that we're trying to get our share, but it's available there, and if it helps our citizens, I'm okay with it.
Yeah. Well, look, I appreciate you. And I really appreciate your staff. Counsel over there, Mr. Williams, always helpful. But I'm just so skeptical of this because the federal government changes things so often, Commissioner. And it'd be just like if I came to any member of this board and said, hey, I've got this business proposition. I want to go into business with me. And they're like, well, how much is it going to cost? Well, it's going to cost between 28 and 37 million. I don't think there's a person sitting in here that'd go into business with me if I couldn't identify that. And I appreciate these hearings, but in my mind, all these moving parts, and I think about, you're looking at, by your own numbers, you're looking at 300 employees just for a call center. How many more support staff are you going to have to operate? It's just I think we're just creating another level of bureaucracy and in a very difficult situation anyway with healthcare. And like I said, this is nothing directed at you, Commissioner. I appreciate you. I value you and your staff. I'm just sharing my thoughts here about all the moving parts and the skepticism that is out there when it comes to what the federal government's doing and planning with the federal government. I just think it's very ambitious is what we're trying to do here. That's just my own thoughts.
Thank you, Senator.
Are there any other questions? Senator Fillingham for a question.
Thank you, Mr. Chairman. Thank you, Commissioner. On this cost savings that you were discussing, and a couple of times on the slide, it talks about Mississippi saving, millions of dollars. Is that savings to the Mississippi consumer, or is that savings to the actual state budget? I mean, are we writing checks, the state of Mississippi?
Senator Fillingham, you're not in the state budget. It's just savings that instead of paying the federal government to operate the exchange, the state would operate it, and you accrue savings. And what you do with those savings is you can create other plans. You can do a lot. You can reduce the premium that people pay for insurance on the exchange. You can do a lot of creative things with it. In the scheme of things, it doesn't sound like a lot of money, but over a period of time, it makes a difference in the quality of life for a lot of people. I did not get into what we call cost sharing reductions real deep, but you might consider that you could use that money for a cost sharing reduction for people that are uninsured.
Sure. So I think you've answered my question, which was we're not talking about saving on a line item budget within the budget that we go over, because we're not paying that as the state. You're talking about savings to the individual consumers who are on the healthcare exchange, and you're saying the state can do it more cheaply than the federal government can do it.
That's correct.
And the net result of those dollars, the state would be the beneficiary of and could use for other purposes.
That's correct. That's an old Reagan economics,
Right.
States of the laboratory, and we do a lot better job.
And then on the Arkansas model that you mentioned just briefly, you said they're sort of in a transition. They moved their program around a bit. Are you familiar with the Arkansas plan?
I am familiar with the Arkansas plan.
Do you subscribe to it? You think it's a good plan? Have they done it in a good way, or they're messing it up?
Well, Senator, since Mississippi designed that plan originally 12 years ago, we thought it was a good plan until they got it screwed up about 5 years ago. Somebody got ambitious and they started doing some creative thinking about what they could do with the money. But basically, it was keeping private insurance in the marketplace. They're trying to go back to the old plan.
So the private health insurance you think is better than the Medicaid insurance?
Absolutely, unequivocally, yes.
Okay. And the people that, if we set up this exchange in Mississippi, is it like a 400% FPL cap on who can participate, or is there no cap at all? Anyone can participate?
Anybody can participate if you're 100% above the federal poverty level.
Up to whatever. There's not a cap on a 400% or anything like that.
Well, if you, there used to be a rule, if you bought a platinum plan, which is the best plan you could buy, you got a 10% out-of-pocket cost reduction. I think you were limited in income to like $500,000 and after that you had to pay some type of luxury tax, but all of that's kind of gone away. So anybody can buy on it.
Gotcha. Thank you, Mr. Chairman.
Thank you. So potentially, individuals, to what Senator Fillingham was saying, anybody can buy on it, and it can be another marketplace for people to get pricing and potentially bring the price down, especially if you bring in more insurers. Is that
correct? And some states are toying with the idea of putting their large groups on state-based market places, and that's something that we just hadn't studied enough to understand, but employers kind of like that. But there's so many rules, like an ERISA plan is an Employee Retirement Income Security Act type plan. They affect 401ks, self-employed, non-fully funded HMOs, that's health maintenance organizations. They're not covered, states and federal governments exempt them from all kind of rules and regulations. And y'all maybe even debate a bill today that brings up ERISA plans are exempt from coverage, and we just follow the law like it is. So the jury's still out on that. I don't think we have federal rules or guidelines on what you do about ERISA plans and self-funded plans. I just don't know how you would put a self-funded plan on right now, but they may come up. We try not to mess with self-funded plans. That's between an employee and employee. And let me make it clear, we do not get involved in networks because some doctor or hospital was not in a network with an insurance company. That's their problem. We don't get involved in that as a commissioner. That's a private contract obligation, and we stay out of it. I'm reiterating that because I was asked that walking over here this morning.
Thank you. Senator Clinton, you have a question? Got about 2 minutes left.
Thank you, Mr. Chairman. Will this do away with the risk pool?
No.
Can you real briefly describe the difference in the two?
Well, the risk pool it was designed originally for people that could not get insurance anywhere as an insurer of last resort. When the ACA passed, most people did away with the risk pool. We kept it alive because we had anticipated and operated in a small business health option plan called a SHOP, and we did for a while. We just couldn't get the numbers up like we needed to. Most of that was due to politics. And so we shut it down. We just didn't want to go in the hole. But the risk pool is there for a reason, and it needs to stay alive and just sit there for nothing until someday it may be needed. And if we get to the point that it's not needed, we'll probably ask the legislature to do away with it. But those states that have kept the risk pool have thought it's worked out quite well. The risk pool would just stay in place.
Thank you. Senator Michelle, you have any questions? All right, motion to rise and report. All those in favor say aye. All opposed? Thank you, Commissioner.
Thank you, Mr. Chairman. Appreciate you.